Hello to everybody. So I think that we can start. So I start with an introduction about our company, our technology. So just few words about me. My name is Gianni Pertici. I'm a chemical engineer. I'm one of the founder of IBI, and I am the inventor of the Smartbone technology. So IBI was founded in 2008 in Switzerland, the south side of Switzerland, and we arrived on the market in 2012. And we start from the dental and maxillofacial market because it's a fast market. You have a direct contact with the surgeon, with the dentist, so you can receive immediately the feedback from clinics. Then we decide to expand our market in the ortho line, the ortho application in 2018, more or less, and we arrive immediately after COVID in this market. So with the ortho line, we cover the oncology, the spinal surgery, the traumatologica, and so on. So here you can see our product portfolio. And obviously we have the dental maxillofacial line, the ortho line, and obviously we have also the custom made that cover all the specific application. So today I want to explain again for most of you the technology behind the product. So we started a long time ago analyzing what we can find on the market as bone substitutes. And we source several products. Obviously, we have the cadaveric bone, some animal-derived materials, and some synthetic material. But all these products are quite far from the gold standard. The gold standard is the material that you harvest from the patient, the healthy bone that you harvest from the patient. So we look at the experience that a Swiss company did onto the market, Geislich. They have a bovine bone substitute, especially used for the dental application. But we saw that for 50 years, they maintain a very good safety of the product. So we decided to start from bovine bone from Australia and New Zealand because in this area, the BSC, the mad cow disease never arrived. So we decided to harvest bovine bone from Australia. And obviously, we analyze the cleaning treatment that a different company do onto this material. So we decide to clean the material with a proprietary treatment at very low temperature to preserve the chemistry of the hydroxyapatite, the chemistry of the bone to preserve the bone, because we want that this material obtain a remodeling, obtain a perfect integration inside the body. Obviously, when you clean the material at low temperature, so when you preserve the chemistry of hydroxyapatite, the risk is that immediately after surgery, you have a problem of resorption of material. So we decide to put some material to improve this kind of characteristic. We put biodegradable polymers to improve the mechanical performance and the volumetric maintenance. And we put also some collagen fragment, in particularly some denaturated collagen to improve the interaction with cells inside the body. So the bovine bone is a material that offers very good safety of this product when you use in surgery, in orthopedic surgery, for example. We put some biodegradable polymers to improve the mechanical performance and the volumetric stability of the product. So we create a kind of coating that cover all the inner trabecula of the bone. Is a kind of glove that we put onto the trabecula of the bone. This glove improves the mechanical performance and also the biological performance. You can see that this material, especially the polymers, stay there for 3-4 months. Then, due to the hydrolysis, they will be transformed in water and absorbed by the blood, by the body. We introduce also some collagen fragment, especially some denaturated collagen that express the RGD sequence, so the cells can connect immediately to the surface of the bone. So we improve the hydrophilicity, obviously, so the graft can absorb the blood quite fast. But as you can see from images, we help also the osteoclast. The osteoclasts are the cells that can destroy the necrotic bone, in this case, the bovine bone, that is a dead bone, a necrotic bone. So the osteoclasts that arrive from the body can adhere immediately to the surface of the graft, of the Smartbone, and can start the integration process. So they start to destroy the necrotic bone, and osteocyte and osteoblast can arrive to regenerate the new bone. Here you can see what happens by histological analysis. You can see a picture of an histological analysis after 4 months after the surgery. So you can see where you can see the black arrows, you can see necrotic bone. So this is bovine bone. We can say this because you can see empty lacunae. So you can see some white spot. There is no cell inside, so it's a necrotic material. And you can see in the green arrows that new material, new bone is formed. So there is a connection, there is a growing of new bone. And here you can see also some osteocyte and osteoblast that's still in activation to create new bone. Here you can see after 7 months a large osteoclast that is destroying the remaining part of bovine bone. Here you can see that we are talking about a coating that we put in the inner cavity of the graft of this spongy bone. But here you can see that we maintain an open and interconnected porosity. So the blood can go inside because we improve the hydrophilicity. The cells can go very deep inside the graft, connect to the surface of the graft, and they can exchange nutrients and waste. So the healing process can go on. Why is Smartbone better than the other material? Here you can see some images, some cases, but obviously Dr. Ellapparadja will explain better this concept better than me because I'm an engineer, I'm not a doctor. But here you can see from the patient one, here you can see this is some maxillofacial cases. Here you can see in the upper jaw there was a large cyst. So the surgeon decided to open, clean the site, and put some microchips to regenerate the bone. You can see that after 30 months, the spongy material, the spongy area is replaced, but also the cortical, the external cortical layer is replaced. You can see probably better in the patient 2 because there is a very, very thin layer of bone, so it's impossible to put an implant in this space. So he decided to perform horizontal bone augmentation, putting a plate, a simple plate, fixing by 2 screws, osteosynthesis screw, and you can see that in 20 months, the cortical layer shift from this in the external part, and also all the spongy material is replaced. Here we can talk about of anatomically selective remodeling. So we have a full remodeling of new bone. We have also some cases, and I'll show you later this case, that at the end, for example, in this case, after 2 years and a half, there is no more evidence of Smartbone. So the material is fully remodeled. here you can see from this histological analysis that we can see some blood vessels. So we have a very, very good vascularization and a fully remodeling process. There is also some independent study that put in comparison Smartbone with, for example, BIOS in dental and maxillofacial surgery. You can understand the BIOS is the material that is the best seller material. They maintain the 60% of the dental market. There are several articles, scientific articles, that put in comparison Smartbone to BIOS. And you can say that within 1 year, the behavior is more or less the same, but you can see from this histological analysis that after 10 years, BIOS is still there. There is no possibility of remodeling. 10 years is a very key point because the circle of life of bone is more or less 10 years. So every 10 years, our bone is replaced. So if you put a graft and after 10 years still there is no possibility of remodeling. Here you can see some material that you can find on the market. And just to summarize the main characteristic of Smartbone, as I said before, we show very, very good volumetric maintenance. We have a full remodeling, very good hydrophilicity. If we talk about the block, the material is very, very strong, easy to shape. There is not the risk of unpredictable fraction during the shaping and during the fixation. And we have very strong scientific evidence. From our website, you can download some scientific papers. We are talking about 100 scientific papers. On the other side, there are other material, as for example, some material that they have a cleaning treatment at very high temperature. This is good for safety reason, but they transform the chemistry of the osteopathy, the chemistry of the bone, and the result is that they cannot obtain a remodeling, a full remodeling. In this case, this material, they have a very, very good volumetric maintenance, but there is no remodeling and also very, very low mechanical performance. So just to advise, but obviously the doctor after me can go deep about this topic, but just some recommendation. I recommend to avoid the use of saline solution, the physiological solution, because this material extract the protein that we add onto our treatment. So the first choice is the blood of the patient, or if you have some problem to collect blood of the patient, you can use sterile water. But please avoid the use, especially the massive use of saline solution. And obviously, we have to evaluate the condition of the patient, if there is some inflammation course, or if we want to obtain a full remodeling, a full replacement of the bone. So we have to evaluate the metabolism of the patient. If the patient show very, very low levels of vitamin D, a very, very high levels of bad cholesterol, probably this is not good for the metabolism of bone, and obviously we can have some, I cannot say failure, but some retard, delay in the regeneration process. I will show you just two, three cases of custom made, very, very fast, just to show you the capability of this material. So this is a maxillofacial case performed in Sweden long time ago. So here you can see some phase of the planning of the cases. We are talking about on the upper jaw. So the starting situation was not nice. There is a very large inflammation. So first the surgeon decided to remove all the teeth, waiting for a healing process. Then we proceed with the surgery. So he opened the flap, detached the soft tissue very well to avoid any kind of tension during the closure. You can see that he fixed the graft by 2 screws. to avoid any kind of micro movement. Here you can see the follow-up after 2 months. You can see that after 2 months, we have to wait some months more to obtain a good integration. You can see that after 8 months, the integration is very good, but also we maintain a very, very volumetric structure. We don't lose volume. So in this case, the surgeon decided to proceed with the surgery. He placed 7 implants. Here you can see the follow-up after 1 year with very, very good aesthetic result. And you can see the follow-up after 7 years. So we preserve the volumetric stability of the graft. We have very, very good stability of implants. So this is a very, very successful result. Another case quite similar with a very, very large atrophy of bone. In this case, the surgeon shape by itself the two grafts, and we scan it and we produce these two grafts. Here you can see that also onto the stereolithographic model, the bone match perfectly onto the site. Here you can see some phase of the surgery. Also in this case, he detached the soft tissue properly to avoid any kind of tension during the closure onto the graft, because if you had too much tension, the risk of graft resorption is quite high. So he detached properly. He fixed by several screws to obtain a very, very good stability and avoid any kind of micro movements. He put also some membranes. We recommend when you have in contact with soft tissue, like in this case, we recommend the use of membranes, for example, collagen membranes or pericardium membranes, because especially in this case that the surgical site is not so clean, to avoid in case of dehiscence, that bacteria can go inside the graft. So we recommend the use of some membranes to protect the graft. And here you can see the reopening. During the reopening, after 9 months, he performed some biopsy to evaluate the integration. We can see that the integration is very, very good because we have very, very good interaction between the bovine bone and the new bone format. But also we can see that we still have a 70% of Smartbone that will be processed later. But the integration was evaluated good by the surgeon, so he decided to proceed with the implant fixation. And here you can see the result after 1 year, after 17 months, and after 8 years. We have a very, very good implant stability, no pain for the surgeon, a very, very good volumetric maintenance. So also in this case, we are talking about very, very successful result. The last one, very, very fast. Here was a maxillo-craniofacial reconstruction. Here you can see that this was a soldier that took a piece of bone in his face. During the war, they put some titanium meshes to replace the zygomatic area and the orbital floor. After several years, the surrounding bone became necrotic, so the orbital floor was going down. So he decided to proceed together with the surgeon to a new surgery. So here you can see the starting situation. So we decide to proceed with a custom made, obviously, because the surgery was quite complicated in this area. We produce 4 pieces because the surgical windows was quite close, quite short. So we produce 4 pieces. Here you can see some phase of the surgery. We produce also some surgical guide to cut the necrotic bone. Here you can see the placement of the 4 pieces. The last one was the positioning of the orbital floor. Here you can see the situation before the surgery and immediately after the surgery. Here you can see the follow-up after 9 months. We can see that we preserve the volumetric structure of the zygomatic area. And after 3.5, the patient decided to go for aesthetic surgery to remove the scar onto his face. And we decided to proceed also with a biopsy to evaluate the integration of the bone. Here you can see that there is no more evidence of bovine bone in the zygomatic area. And we can see a lot of blood cells, so we can see a lot of blood vessels, so a very, very good vascularization. So also in this case, we obtain a full remodeling of the graft, no volumetric resorption, so a very, very good result. So I don't want to waste your time because we have Dr. Ellapparadja that is waiting. So I stop the sharing of my screen and I prefer to pass the end to Dr. Pregash. So I let Dr. Pregash to do a fast introduction about himself and his activity.
Can you see my slides?
I can see perfectly your slide. Yeah.
Hi.
Great.
Good evening. My name is Pregash Ellapparadja. I'm a consultant knee surgeon currently in Manchester, and I'm pleased to share my experience with the Smartbone wedges. I have no relevant disclosures, and more importantly, I think nowadays this is important. I have not used ChatGPT to get this presentation done. So, osteotomy. So why knee osteotomy? Because I always felt that the osteotomy was a last art, because though originally osteotomy was quite successful in the 60s and the 70s, with Chanley's invention of arthroplasty and arthroplasty becoming more successful, feel that osteotomy took a backstage because of not the very high success rate when compared with an arthroplasty. And I think the high success rate of arthroplasty, especially the knees, eclipsed the knee osteotomy in the early 90s and 2000. But over the last 25 years, osteotomy has had quite a significant revival. As primarily because we now have a very clear understanding of the biomechanics of the knee. Our surgical techniques have quite significantly improved, and we have also got better implants that is producing good results. And now we have got a national joint registry in the United Kingdom, where we are inputting all the data regarding the osteotomy results, and we are seeing how well we are doing. And this has been going on for nearly 8 to 10 years now. So if you see on this X-ray, you can see that that's a long leg film who has had an osteotomy using a Tomofix plate. And we aim to correct just beyond neutral, which is a sweet spot, we say, so that we overload the normal lateral compartment. So the osteotomy technique. So the most commonly used technique is high tibial osteotomy, because most of the times, it's a middle compartment osteoarthritis with the tibia being in varus. And though in the olden days, we used to do a lateral closing wedge osteotomy because of the fact that the common peroneal nerve comes around the lateral side. And obviously, you don't want to deal with the nerve issues. So more and more, we are now doing open wedge osteotomy. And the correction of the weight-bearing axis, as you can see on this black line on the X-ray, is around 52 to 52%, 52 to 55% when you measure it from the medial side of the tibia. And you can see this yellow line, which is this normal weight-bearing axis, is actually overloading his middle compartment. So I call it robbing Peter to pay Paul. So basically, you are trying to overload the healthy compartment, thereby protecting your worn-out middle compartment. So the ideal correction, this has always been an enigma, because when first it was pointed out, it was a Fujisawa point, which was accepted as the spot where you have to correct the osteotomy in the 70s and the 60s. But then what we realized is that Fujisawa point is approximately 62.5% into the lateral compartment when you measure it from the edge of the medial plateau. And this always led to severe overloading of the lateral compartment. And subsequently, what studies have actually shown is that the people who had their osteotomy corrected to the Fujisawa point started developing osteoarthritis of the lateral compartment. In 3 to 5 years, they started developing symptoms to the lateral compartment. And by 7-8 years, they have had severe lateral compartment osteoarthritis, and they were forced to do more procedures thereby leading to failure of osteotomy. So now we know that from the biomechanical studies, even correcting the osteotomy towards the midpoint of the knee actually starts overloading the lateral compartment. And we call it as a healthy neutral, where we try and correct it between 50 to 55%. Again, there is no universal concern. Some people will correct it to 52, some people will correct it to 55. But we do know that the more you go beyond 55 to 60, then you are overloading the lateral compartment quite significantly. And this actually leads to overloading and more chances that you will create arthritic changes in the lateral compartment, and thereby the duration of the period for which the osteotomy works also diminishes, and you will have eventually to do more procedures. Hence, I would say 50 to 55% is the healthy neutral, where you will get a very good osteotomy results. And that will be the zone between the yellow line and the pink line. So just a quick recap how we correct the osteotomy. So on the left side, on the patient's right side, you can see he has got a significant varus deformity, where the medial proximal tibial angle is around 83 degrees, while the lateral distal femoral angle is 86 degrees, which is close to the normal of 88. So most of his deformity is actually in the tibia, and so he needs a high tibial osteotomy. While on the other leg, you can actually see that on his left leg, he has got normal measurements of 90 degree of lateral distal femoral angle, while the medial proximal tibial angle is 88 degrees. And obviously, he is asymptomatic on the other side. So I'm just going to take you through a case which I did. So this is the case which I think you have seen the x-rays before. So this is a gentleman who is in his early 50s. So he has developed severe medial compartment osteoarthritis. And as you can see from his weight bearing axis, which is going from the center of his hip to his center of his ankle, so it's overloading his medial compartment. So I aim to correct it to 55%. So the black line is the desired weight bearing axis. So as you can see, I've done the osteotomy there. And if you can see grossly, I think it looks like it's going in the middle of the knee. But if you observe very closely, this pink line, again, this is the black line, which is the same. It's actually not going exactly through the center, but it is actually going only at 49%. So in this x-ray, if you can see, this is the black line. So it's going at 49%, while my desired correction was in the pink line, which should have been 55%. So if you look at the correction, I've not hugely undercorrected him, but however, symptomatic wise, he was very unhappy because he is a police officer. So he wants to get back to running, and he's on the field, chasing the thieves. So he wanted to get as active as possible, and he wasn't very happy with the correction. He said that I still have pain. I'm not very happy with the correction that I've achieved. And he says that I can't get on the field. So essentially, he had to get back to a desk job. So he had to get his job redesigned for him. And obviously, he wasn't very happy with the procedure. So when I analyzed what has happened, so I could see that though I wanted to correct the wedge to around 10 millimeters, unfortunately, I could see that the wedge wasn't corrected to 10 and it was actually corrected to 8 millimeters. So the main reason for the loss of correction was when I used the bone wedge before putting the plate, because the standard bone wedges, they are not very strong. So when you're trying to put the plate, there is a pressure on the bone wedge and it crumbles a bit. And this actually led to a decrease in height. And this even small loss of height actually led to undercorrection of the osteotomy, and it actually led to failure. And since osteotomy is done for patients, who are quite demanding and who want to get back into physical activity, so this patient wasn't happy at all. So I had to take off the osteotomy and I had to do a medial unicompartmental knee replacement, primarily because he said he didn't want me to revise his osteotomy. And because he has moved to a desk job, he said he is not going to do any running anymore. So he'll be desk-based job. So he said he's happy with just some pain relief. I know a few of you will do arthroplasty. I wasn't very happy with this because there was a slight medial overload. As you can see, there's a bit of a medial overhang of the tibial plateau on the tray. But however, he was very happy with the procedure because it took off all his pain relief, and he's now back at his desk as a desk-based police officer. He's carrying on with his day-to-day activities. So I've had a couple of failures like this, and all because of the fact that, very minimal change in height leading to alteration of your osteotomy correction. So what was the reason I started using the Smartbone wedges? I was actually in a European meeting when I saw in one of the stalls where the representatives were there. So there was this guy who was actually putting a drill bit through this bone wedge, and the bone wedge didn't break. That came as a big surprise for me, because whatever type of bone wedges or the artificial bone grafts I've been using for my practice, they are very crumbly, or you can break it with your hand. And I could see that this bone wedge was so strong, you can actually pass a drill bit, and you can actually put a screw in, and still it didn't break. So that clearly demonstrated to me the excellent mechanical properties of this bone wedge. And I think these are the main advantages I feel, with the smart bone wedge. Its main thing is the strength, because it's a load sharing device. The second thing is, because it is so strong, once you put it into the osteotomy cap, it doesn't collapse. So it leads to maintenance of the accuracy of your correction. And secondly, if you want to trim, for example, if you've got an 8 millimeter wedge, but you want only a 7 millimeter correction, you can trim it with a saw, just like you cut on a femoral head. It is so strong, you can nicely skim it, reduce it to a 7 millimeter wedge. Whereas with the other commercially available bone grafts, the moment you start using a saw, they crumble. Whereas this one, it is so resistant that you can actually nicely take a sleeve of the bone of the graft, and you can get your geometry that you want, and still it is very stable, and you can actually insert it into the cap. And the last but not the least, it's a scaffold, as Gianni has already explained. So it is a scaffold on which the blood supply grows, and the new the bone cells come in, they resorb this bone, and over a period of time, as you have seen in the histological slides, new bone gets incorporated, and eventually after 2-3 years, you will not find the remnants of this graft at all. So essentially, new bone has grown into it, and it has replaced this bovine graft. So how does this translate into clinical benefits? So as Gianni has said, this actually absorbs the blood, which is fantastic in case of an high tibial osteotomy, because you have got raw cancellous bone, and there's a lot of bleeding that happens in this open space. So by putting this bone graft, it absorbs all the hematoma, and this completely prevents any hematoma formation. And as you know, hematoma formation is always a risk for infection, and this can be prevented by this bone graft. The second thing is that, as we already know, it has got excellent strength. The mechanical properties are so strong, it allows immediate weight bearing. So with this graft put in, I have no issues at all. I let my patients weight bear straight away after the surgery. And this has actually led to me doing a lot of patients as a day case. So I do them the first thing in the morning. So by midday, they are up and about with the crutches. Physios see them, show the exercises, and by evening, they are ready to go home. So I'm going to show you a few cases which I've done with the smart bone graft. So the first gentleman, he's a 46-year-old male. He was referred from one of the neighboring hospitals. He had an early medial osteoarthritis with a lax PCL. He was a builder by profession, and he was very keen on knee preservation. So he had gone to a few of the consultants who advised him a knee replacement, because he also had a lax PCL. So he wasn't very keen on knee replacement because he wanted to preserve his knee, as he was a builder, and he said that he wanted to do a lot of heavy lifting, and he wasn't very keen on a major procedure like a knee replacement. And during clinical examination, I found that his PCL was only grade 2 laxity. To be fair, his PCL was not his main symptoms, and his main symptom was his medial osteoarthritis. But I did explain to him that after the osteotomy, if he did have any symptoms of PCL, then as a secondary procedure, we might have to do a PCL reconstruction. So on the left side, you can actually see that is his weight-bearing axis view, where he's overloading his medial compartment. And on the right side, you can actually see on the trauma CAD. So one good thing is that, we have got various instrument software techniques which are available on the market. You can use OrthoView, or you can use trauma CAD, Sectra, whichever is available in your hospital. So I used trauma CAD for this case, and it showed me I had to correct around 9.4 millimeters opening wedge. So just quickly going through the fluoroscopy images. So I know many of you will be doing osteotomy and you'll be familiar with these procedures. So I use 2 parallel guide wires and aim for the tip of the fibular head, so that you don't risk a fracture into the tibial plateau. I always use a precision saw, which is a very good instrumentation because it's just the tip of the saw that is doing the oscillation. So again, it protects against the posterior neurovascular structures so that you don't end up damaging the popliteal artery. So once I've made the saw, then you gently open up the osteotomy, and finally you put a wedge to open it. And now, as you can see on the picture, so already the graft is in place, and I've put the plates. Check with the images whether the plate is sufficient enough and it is in the adequate position. And the other X-rays show the AP in the lateral view with the wedge in position. So this is actually a new clip plate, which is much smaller and more user-friendly. So this is 1 year showing excellent graft incorporation. You can see both the AP and the lateral views. So the graft has nicely healed and it is getting incorporated. As you can take up to 2 to 2.5 years before it is fully incorporated. But as you can see, it's already started getting incorporated. He was delighted with the outcome, as I can show you in his long leg films. So as you can see, I've just pushed him into mild valgus, which is around 55%. He didn't need any PCL surgery because he was very happy with the outcome. He's back at work as a builder. So another case, he's a 64-year-old male. He's a very keen runner, again with early medial osteoarthritis, where he's overloading his medial compartment. But however, again, he wasn't keen on any major replacement surgeries because he wanted to continue running, and so he was a candidate for osteotomy. And again, this is his X-rays. So you can see that he's overloading his medial compartment on the right side. So this is his X-rays at 1 year. Sorry, this is at 6 months. So you can see that I've just pushed him to neutral, and this is at 1 year, and you can see that there is a bit of bone graft seen there. And again, in his case, I had to do a infratubercle osteotomy, primarily because, as you can see, I've drawn the indices of the patella. So he has an element of patella baja, and I didn't want to do a supratubercle osteotomy. I didn't want to do the cut going up because that can actually predispose to moving the patella down, leading to patella baja. So I've deliberately done an infratubercle osteotomy. And as you can see, there is already incorporation of the the bone graft in the lateral view. And this is even at 1 year, and you can see that pretty much a lot of the graft has been incorporated in the bone. He's now back at running, and to be fair, he has got similar symptoms on his other side, and he is already on the waiting list for his left knee. So this is another case where I used a tomofix plate. When I started my osteotomy fellowship, I was doing the tomofix plate, which used to be the gold standard like 8-9 years ago. But however, now we do know that tomofix plate is quite bulky, and we always end up removing the plate, and hence we have moved to the new clip plate. And as you can see here in the fluoroscopy views, so the bone graft there holding the wedge open, and the AP and the lateral view of the tomofix plate. So this is only at 4 months. Still, as you can see, the graft is still not completely incorporated, and you can still see the graft. But on the lateral view, you can already see that the osteotomy, the biplanar osteotomy, the osteotomy has actually healed in this plane where you have the supratubercle cut. So that has healed, and so the healing has already started, but still a long way to go. And this is another case where again I used the new clip plate, so you can see the graft holding in place both in the AP and the lateral view. And this is again at 1 year. So you can see that the graft is getting incorporated in place, and you can see that tubercle osteotomy has healed. Incidentally, he has also had a similar procedure on the other side, which is already healed with the plate being removed. So as you can see, osteotomy is a knee preservation technique. You can do it for people who are keen on involved in sports, lifting heavy weights. But however, now I've expanded my indications. I do it for anybody who wants to have an active lifestyle and who is not keen on getting major metal work inside their body. We know that arthroplasty is a very good technique, but however, people would like to preserve their own knee if possible, and they want to do a lot of physical activities. So I offer them osteotomy when possible. However, the important thing to note in osteotomy is that accuracy of correction is vital in knee osteotomy. And now for me, Smartbone has become an indispensable gadget in the knee osteotomy algorithm, because once I put the graft in, I know that the correction is not going to change. And then I put the plate in, and I know that because it is very strong, I can let them weight bear straight away after the surgery. Often I do it as a day case unless patient has any pain issues when he will stay overnight. So what does the future behold for osteotomy? So we do know that this is a very strong graft there is a news going on that, in London, by 2026 year end, we'll be having driverless cars. So what's the future for osteotomy? Should we be thinking about implantless osteotomy because we have got very strong bone grafts? So should we be just thinking about putting the bone graft and start letting them weight bear, because it is such a strong bone graft? I think I've seen a picture where a car tire goes over the bone graft and it doesn't get crushed. I'm surprised, Gianni, you didn't show that picture. So I think probably, implantless osteotomy is the future with such strong bone grafts. So we should start questioning, should we be thinking about going ahead with the implantless high table osteotomies? But that is, question for the future. Thank you.
So thank you, Prakash, because the presentation is really, really good, interesting. I was thinking about, obviously, about the future, because it is an idea that I have from long time. So I would like to avoid the use of titanium plate fixation, because especially in young patients, I think that they come back to play football without titanium mesh, titanium plate. So, and or probably I think that probably in future we can evaluate to do a study, some specific case, probably some young patient start to think to use just the wedge, or probably we can produce some plate made by Smartbone to obtain a good stability. But yeah, it's a good idea, and probably we will work on it during the next month.
Absolutely.
So I would like to understand if there are some questions from the platea. Yeah, please. Yeah.
Chris, I think you're on mute.
Sorry.
Yep.
Thank you. That was a brilliant presentation. Are you seeing, I know the Tomofix was bulky. Are you seeing you still have to go in and remove a lot of the new clip plates?
Well, personally, that is my experience. I've had to remove quite a few new clip plates, because when I moved towards the new clip, I did think that, it was quite sleek and thin, and I presumed that I wouldn't have had to remove. But this is what it is, at the end of the day, you go by evidence. And I have had to remove 50% of my patients, the new clip plates. And I was really taken aback, because that was my selling point when I started using the new clip plate. I used to tell the patients that we just do the surgery and we don't have to use it. I mean, we don't have to remove it. But then a lot of patients, because, they are very keen runners, and a lot of them are, quite skinny. And what happens is that, it's just the skin stretches over the plate, and they exactly come and say that, I'm feeling very, very uncomfortable. Can we remove them? But as a rule, I usually don't remove any plate for the first 1 year, and I managed to drag it to a year. And then after that, if they still insist, I have to remove them, because they're not very happy. But once you remove them, they're actually delighted with the symptoms, and they say like, oh, it was worth it. Yeah.
That's the thing, because there's a lot of soft tissue working over the top of that plate, isn't there?
Yes, exactly. And, I used to think that, that was the biggest disadvantage of Tomofix, but I'm really surprised that, even with the new clip, in spite of being nice and smooth, still we have patients complaining about the soft tissue irritation.
Yeah, I mean, it's great to know, because there's a huge amount of new clip down my way in the south. And the other one was, I know there's a massive difference between physiological age and chronological age. But I mean, a high tibial osteotomy in a 64-year-old, a lot of people would have gone straight for a uni knee.
Absolutely.
Do you have any cutoffs or guides in terms of? I know it's a grey area; it's difficult.
It is difficult, but I mean, to be fair, I asked these guys, and I put it to them, to be fair. I said to them, like, with the uni, yeah, you can do a bit of jogging, maybe you can run maybe like 3 to 5 Ks. But then, you get the guys who run marathons and stuff. I mean, there's no right or wrong answer, but I feel a bit worried when people say that I'm going to run triathlons and marathons and all these things. And we do know that the unis last for a good 15 to 20 odd years. But however, these studies have not been done in somebody who does triathlons and marathons. So you're always wary that, they might loosen it. And so, I give them the option of osteotomy. And I don't know how you do it in your practice. And then I often give them a medial offloading brace. And then they come back and say, like, this is brilliant. And then, once they say that, it has completely relieved their symptoms of the brace or even partially. So I go for a high table osteotomy. But if someone says, like, they're an occasional jogger or like, they just go for walks and stuff, then probably I will push towards a uni. I do agree, because I do both of them at the same time. And, I am quite particular, like not to do in someone who is very sedentary. I offer them a uni straight away. Whereas somebody who is very physically active, and then, you get these builders, crazy builders, who want to continue working till 70 and stuff. And they get sold out by this idea of osteotomy and they love it. And they are one of those guys, who are very happy. Even, they don't need extreme pain relief. As long as you give them moderate pain relief, they're delighted with it and they just carry on working for the next 10 odd years.
And from the looks of things, you're using a fixed bearing uni, so you don't have to worry about bearing dislocation.
Absolutely. Absolutely. Spot on.
Thank you very much.
Thank you. Yes, I think Hamid, your hand is raised.
Hamid, yeah.
Hi, thank you again, Prakash, for the presentation and giving your overview. Obviously, I've supported the cases that we've done. I wanted you to just share your actual handling of the product and what was your initial reactions compared to when you've handled allograft and autograft for the rest of the group, because there are a lot of these groups are distributors here today, and I want them to really understand what, from a surgeon's point of view, how you felt it handled when you were impacting it in, the general feel of it, when you've had to trim the product down, when you've had screws going near it, etc. How that initial kind of feeling was for when you were holding that product in a clinical setting.
Yeah. So, I mean, I think most of you guys, a lot of surgeons and obviously distributors are there who would have had theater experience. So it felt as strong as like a proper bone graft, like a cortical bone graft. So handling, you can't break it with your hand. It is rigid, and you can actually tap it into the osteotomy space, and it will not break. So you don't have to worry about it. You can give it a good punch, and it goes and nicely gets wedged in the space. So it's not like the standard bone grafts where you use, if you bang it, you are always worried because it can crumble, and then it can break into two pieces. You don't have any of those issues there. It's a solid, strong bone graft, which you can actually bang it. And as I said, you can actually, if you want, you can pass a drill bit through it, and you can actually tighten the screw there, and it will not break. It's that strong, and I've seen it physically. So once I saw it, I thought like this is a game changer, especially with osteotomy where correction is the key, where you want exactly the wedge to be open to precise millimeter. I think this was a game changer. And again, you don't have wedges available, unfortunately, to every size. I think you've got like 8, 10, and that sort of stuff. So if you want to get it down to 9, just like you take your bone graft, like for example, if you're doing an ACL, the bone patella tendon graft, you can actually trim the bone patella tendon. The same thing with a saw, you can cut this bone graft and it'll be precise, and there'll be no splintering of the graft. So it's brilliant, and it's very user friendly. So you can handle it with 2 cockers, hold it, and then cut it with a saw, and then you can put back once it has reached the desired amount, put back into the wedge, and you can nicely tap it back with a tamper, and it will occlude the osteotomy gap.
Prakash, one last thing. When you did the first HDO osteotomy with the Smartbone wedge,
yes.
When you first introduced the wedge, we initially, before we put the plate and screw the construct on, you ran it through a range of motions under fluoroscopy as well. Can you just explain to the group how that felt, actually having just a graft supporting the height of your correction, please?
So once I put in the wedge, and then I took it through the range of motion, and it was so solid, I mean, there was no, what would I say? There was no secondary motion at the hinge or no feeling of wobbliness, which you might feel with a standard bone graft. It was solid, rock solid. It got wedged in nicely, and then I could take the knee through the full range of knee movements, and the osteotomy felt very stable. To which point I was actually commenting to Hamid that should we really be putting the plate? This feels really rock solid. But obviously, we don't have evidence to show that, we can just put the wedge in and then forget about it. So we put the plate in, but it gave us the full confidence that, we can let the patient weight bear straight away. Because even with Tomofix, when I was doing the fellowship, I grew up with Tomofix. So we always used to let the patient weight bear, even partial weight bearing after 2 weeks. Whereas with this one, I've been letting patients weight bear, full weight bearing from day one. It's been absolutely fine. So no collapse, no loss of, reduction or anything like that. And there's been no fractures or periprosthetic complications. Thankfully, everything has been fine. Hello, Mr. Isam.
Oh, sorry. So this is Debbie.
Hi,
so
Debbie.
I'm in Manchester as well.
Hi.
I used to be your EpiSurf rep a very long time ago. So no, thank you for that. It's really like the fact that you have your patients weight bearing that day is absolutely astonishing, and it's absolutely mind blowing. So thank you for that. I think sometimes when you're quite new to a product, so I've only been with Sovereign a few months. It's having that confidence of listening to somebody like yourself.
Yes.
That actually tells you it does it really is as strong as what you think it is.
It is.
So thank you, and I'll be coming to some of your cases soon, hopefully.
Thank you. You're welcome. Yeah, you're welcome, Debbie.
So if there is no more question, I would like to say thank you for Pregash for the beautiful
Thanks, Gianni, for
presentation.
your
Really.
invitation.
Yeah. I will contact you for some idea.
Thanks, Hamid, for your help as well. Thank you very much. Much appreciated.
So,
thank you.
Thank you to everybody, and
thank you.
I will inform you about the next webinar and the next event. So thank you to everybody. Good evening.
Thank you.
Bye bye.
Good evening. Thank you. Bye.
Thanks a lot, everyone. Take care. Bye bye.
Ciao to all of you.